Hello class, I'm going to provide you the lecture for week 3, day 2 on our concept of tissue integrity with the exemplar of pressure ulcers. This exemplar is not new to you. We talked a little bit about pressure ulcers in Nursing 100, and we know the term pressure ulcers can even be called bed sores, or also we've heard it termed as decubitus ulcers as well. So let's go through this PowerPoint, and I'll also point out some important things from your assigned reading as well. So let's first talk about exactly what is a pressure ulcer. A pressure ulcer is a ischemic lesion of skin or underlining tissue. What's happening is, with that pressure on that area, that's when a patient is in that position for a long period of time, it's limiting blood flow through that area, and that's what's causing necrosis and ulceration. That's what the term ischemic means. It means a lack of blood flow, so that area, those tissues, those cells are not getting enough nutrients and oxygen to the area. And so what happens is it starts to break down and ulcerate, and necrosis is when the tissue actually dies because there is a lack of oxygen and nutrients to the area. We know that pressure ulcers occur a high incidence in hospitals, long-term facilities, and in home settings as well. And your book talks about the data that shows that within hospitals, the incidence of pressure ulcers can be as high as 8%, and the incidence in long-term care facilities can range anywhere from 2.4% all the way up to 23%. And I guess they don't have enough data to inform us about the extent of the problem that's happening actually in the home, but I'm sure it's as high as well. It's very high as well. But we know that with the increasing number of patients, especially older adult patients that are being cared for in the home, I bet that number may be as high as what's occurring in the long-term facilities, or it could even be higher, just depending on the reason why a patient has developed a pressure ulcer. Okay, so let's look at the etiology of a pressure ulcer. It's caused by external pressure that impairs blood flow, and it's caused by forces that tear and injure vessels, about those shearing forces, and about pressure that's on that particular area. And we know that it is not good for a person to be immobile, or a person to lie or sit in one position for an extended length of time without moving, okay? And especially when we see pressure on tissues between a bony prominence and the external surface of the body, will actually start to distort the capillaries, and it really does interfere with normal blood flow. So that's why this is such an important nursing intervention, to be able to assess patients who are at risk for pressure ulcers. And we're going to talk in just a few minutes about what are those risk factors of why some people, are more prone to pressure ulcers, why others are less prone to develop them. Okay. And I just wanted to kind of clarify what the term shearing forces means. Shearing forces results when the tissue layer slides over another tissue. And so what happens is, within that area, there's a stretching and a bending of the blood vessels, which cause injury and thrombus. And a thrombus is kind of a fancy term for like a clot to occur. And our patients are very subject to this shearing forces when the head of the bed is elevated and that torso continues to slide down to the foot of the bed. And that's why you see patients a lot of times where they slide down and we're constantly trying to pull them up in bed so they're more comfortable. And what we have to remember is we do not want to take those patients and drag them across the sheets, because that's also creating that shearing force that makes the area, especially the buttocks and the bony prominences, more susceptible to a pressure ulcer. That's why as nurses and other ancillary personnel that are caring for patients need to actually lift the patient up instead of pulling on the patient. And so a very important care that we give our patients to make sure that that's not being done to the patient, that they're being pulled up properly in bed. I know people don't purposefully mean to make them more at risk for pressure ulcers, but you as the RN need to make sure that the patients are being lifted correctly, all right, to prevent those shearing forces from occurring. So let's talk about the risk factors of what are they that would make someone more prone to developing these pressure ulcers. Immobility is a big one, okay? Anybody that has any type of limited mobility, such as a quadriplegia, patients who are in critical care who are not able to get out of bed or even have the ability to even sit in a chair. Inactivity along with inadequate nutrition, when a patient has fecal urinary incontinence, a decreased mental status, diminished sensation, excessive body heat, advanced age, and the presence of certain other chronic conditions. So, of course, these are all listed on this particular slide of the PowerPoint, okay? And then, of course, advanced age, loss of lean body mass, the generalized thinning of the epidermis, decreased strength, elasticity of skin, increased dryness, diminished pain perception, as I said before, and diminish venous arterial flow. So let's talk a little bit about each of these individually. Immobility refers to that decrease in the amount and control of movement that a person may have. Many times if someone's uncomfortable in bed, they have the ability to move around from, pressures on certain areas of the body, if their back's bothering them or their legs are aching. Healthy people rarely exceed any problems with tolerating that pain that one might feel when there's an excessive amount of pressure on a certain area. But if someone suffers from paralysis, they're weak, or they have pain, or anything that may decrease the normal amount of activity that they do on a daily basis, this is where pressure ulcers can begin to start. And nutrition is also a big one. Someone that continues to have prolonged inadequate nutrition, which causes someone to lose a lot of weight, muscle atrophy, and even the loss of subcutaneous tissue. These processes reduce the amount of padding between the skin and the bones, thus increasing one's risk for pressure ulcers. Also, if we look at certain nutrients in the diet, if they're inadequate protein, carbohydrates, fluids, zinc, and vitamin C, if they're lacking those also contribute to pressure ulcer formation. Hypoproteinemia, which is abnormally low protein content in the blood due to whatever, from not getting enough from their diet, or if they're having an excessive loss due to some kind of pathology that's occurring, predisposes the patient to dependent edema. We talked about the importance of proteins, especially albumin, that keeps that onconic pressure within the vascular space. And any type of edema, swelling that's caused by excess fluid trapped in body tissues makes the skin obviously more prone to injury because it affects the integrity of the skin, decreasing its elasticity, resilience, and vitality. And edema also increases the distance between the capillaries and the cell, thereby decreasing the amount of oxygen that gets to that particular area. And we know about fecal and urinary incontinence. Moisture from incontinence promotes skin maceration. And then, of course, all those digestive enzymes in feces and gastric tube drainage and urea and urine contribute to skin becoming excoriated. And then, of course, any decreased mental status, someone that has a decreased level of awareness, including someone that might be unconscious. And think about the patients who we give some opiates or excessive pain medication, where we sedate them from, anti-anxiety meds or things to help them relax, or have at least dementia, are also at risk for pressure ulcers because they are less able to recognize and respond to that pain that's associated with prolonged pressure. And then look at diminished sensation, and that pretty much speaks for itself. Anybody who suffered from any type of paralysis, stroke, or other neurological problems may cause loss of sensation in a certain body area. So many of these patients may lose their sensation. That reduces that person's ability to respond to trauma, to even temperature changes such as hot and cold, and even to tingling. You know how if your arm falls asleep, you kind of feel like those pins and needles? Well, some people with neurological problems may not feel that and be able to respond accordingly. Okay. Excessive body heat is another factor that is in the development of pressure ulcers. Anytime there's an elevated body temperature, increases the metabolic rate, thus increasing the cell's need for oxygen. So this increased need is particularly severe in the cells of an area under pressure, which are already oxygen depleted. Okay. And of course, we know about advanced age because of the changes that occur in the skin and its supporting structures. Some of the medical conditions that make a person more prone to pressure ulcers, and one big one is any type of diabetes, whether it's type 1 or type 2, and then of course people with cardiovascular disease. Other factors are just what I talked about earlier, where poor lifting and transferring techniques by people who are who care for these patients, incorrect positioning, hard support surfaces, and incorrect application of pressure relieving devices. So, what we have to do is prevent pressure ulcers by, combining actively promoting optimal skin integrity with educating the patient, support people, and caregivers about how to prevent pressure ulcers. And that's the whole big gist of this, is that everyone involved needs to be educated. And I'm going to talk about some studies that were done with pressure ulcers, and the bottom line was about education, not only for the patient, but for the people who care for these patients. This really is a great way that we can reduce the incidence of pressure ulcers with our patients, okay? So I hope that makes it a little bit clearer. So right here we have, to sum it up, prevention is providing nutrition, maintaining skin hygiene, avoiding skin trauma, smooth, firm, wrinkle-free foundation, making sure the patients aren't laying or sitting on a lot of wrinkles in their beds, correct positioning, transferring, turning at least every 2 hours, but some patients may need to be turned more frequently than that. And of course, just like I said, proper lifting as well. and providing supportive devices, overlay mattresses on top of standard bed mattresses, and specialty beds replacing hospital beds, kinetic beds, and continuous passive motion or oscillation as well. So up here on the slide are clinical manifestations, and your book has a really nice picture. It's much more colorful than what we see up here on the screen about pressure injury staging. It's on page 1623 in your Concepts Volume 2 book, and it is in Table 2110, which gives you all the stages and talks about this description of each of them. Stage 1 is when the patient starts to experience non-blanchable erythema of intact skin, and now you see the skin gets to be a little bit white, and usually these areas happen over a bony prominence, and sometimes it's hard to see initially if you're not really looking for it, especially in patients with darkly pigmented skin. But please review this nice picture of all these stages, and kind of gives you a good idea of what you're looking for when you think of stage 1, stage 2, stage 3, and stage 4. Stage 2 is where now the patient experiences partial thickness, skin loss involving the dermis. Stage 2 pressure ulcers present as very shallow. They look like an open ulcer with some pink or red moist wound bed. And now you might see some sloughing of the tissue. Granulation and eschar are not present. And these injuries may also present as intact or open serum-filled blisters. And the picture that is in your book looks like it's on the lower back in the coccyx area, where you see again a bony prominence. Stage 3 is when the patient does experience full thickness skin loss involving damage or necrosis of subcutaneous tissue. Adipose tissue is visible within the ulcer. This is very, very deep. Granulation and rolled wound edges are often present, sometimes, but at this point yet, we still do not see bones, tendons, and muscles are not exposed. But the ulcer presents critically as a very deep crater with or without undermining or tunneling of the adjacent tissue. You have sloughing and or eschar may be present. And then of course stage 4 is the patient does have full thickness skin loss with extensive tissue damage and necrosis, and fascia, muscle, ligaments, and cartilage, tendons, and or bone are exposed and directly palpable. You have sloughing or eschar may be present, and undermining and tunneling and rolled wound edges are usually present. So this is a very serious pressure ulcer. These are very difficult to heal. At this point, they may not be painful, especially if patients are diabetic. Sometimes they've lost a lot of that sensation as well. All right. So those are stage 1, stage 2, stage 3, and stage 4. So interventions, especially looking at the non-pharmacological ones, the non-pharmacologic therapies. Again, I can't stress the importance of patient education to prevent ulcers, and even how we care for ulcers. The good thing is that we see when a person develops a pressure ulcer, especially when they come from home and maybe they're already at a stage 3 or stage 4. This is very challenging for nurses. But as I said before, what's good is that a lot of our hospitals particularly, or even some of the long-term care facilities, do have wound nurses that strictly care for the wounds of some of these patients. And it does require a BSN to be a wound nurse. And a lot of them are so excellent, and I have so much knowledge about the various types of dressings and therapies to use with patients depending on what stage their ulcer is at. They really come around and do thorough assessments on these wounds. So I would suggest that anytime you have an opportunity to work with a wound nurse or to kind of shadow a wound nurse and see what they do on a daily basis, I guarantee you it will be a very valuable experience, because you're going to learn so much with that particular nurse. And she'll show you a lot of things that she does in order to try to get these pressure ulcers to heal. And again, all that she or he would do as a wound care nurse definitely should follow agency protocols and, of course, the primary care provider's orders. But a lot of times docs don't even know as much as these wound care nurses, and will definitely accept suggestions as to the particular mode of therapy that that person should obviously have ordered for them. When we're trying to treat a pressure ulcer, obviously it makes sense to minimize any type of pressure on that ulcer. We want to reposition the patient at least every 2 hours and really record those position changes so that everybody is doing that. And we want to clean that area every time we're going to do a dressing change. And how we clean it depends on the stage, of course, like I said before, of the ulcer, and of course the products that are available, and of course the agency protocol as well. Anytime we clean and dress the ulcer, we use surgical asepsis. Never use alcohol or any type of hydrogen peroxide, as they are cytotoxic to tissue beds. And if the pressure injury is infected, then usually what they'll do is, if it's draining, an exudate, as we talked about in day 1 PowerPoint, then we would definitely obtain a sample of that drainage and get a culture and sensitivity to check what organism might be growing in that wound, and then we can treat it accordingly with antibiotics. And if the patient is conscious and able to participate in the care of that ulcer, we would really teach the patient how to move and to keep off of that particular area where the pressure ulcer is at. Even just moving slightly when they think about it, when they're laying in bed watching TV, will definitely increase circulation as well. And a lot of times we can put assistive devices on the bed to get that patient to get off of that area as well. Also, if we can get the patients out of the bed and get them more mobile and provide a lot of range of motions, which will increase circulation to the areas, that would be very good to do as well. Okay, so just wanted to go over that with you as well. Okay. All right, moving on. The next 2 slides pretty much sum up what's in the table on 1622 in your concepts book about, is it 1622, or there's a chart about the various types of products used to treat these ulcers. I'm sorry, it's on page 1626, yes. It just talks about stage 1 and stage 2, about the different types of products that you would use for that particular pressure ulcer when it's staged accordingly. Okay, so you might want to go over this. You'll get more of this information in lab. We actually have hands-on where these dressings are in lab that you can kind of look at them and have an idea of what certain dressings are used for what type of pressure ulcers, depending on the stage of that pressure ulcer. But you'll get more familiar with some of the hydrocolloid dressings and some of the transparent dressings as well. But these are some of the products, and probably since this book was written, there's probably some new products out now that can be very helpful. Now, when our patients unfortunately develop these stage 3 and stage 4, many times these are so difficult to heal, especially if these patients are diabetics who've been diabetics for many, many years. Many times what they'll put on these patients is those vacuum-assisted closure devices, which really, really help heal that area very, very well. So that really is about as much information from the PowerPoint that I wanted to make sure that you get. And, continue reading. There's also a nice picture on page 1627 that shows the various body pressure areas that we may see these, unfortunately, pressure ulcers develop. So I'd really like you to look at that because a lot of times we think we're turning the patients in a safe position, but really we're just putting them in another position that makes them very, very prone to developing some kind of pressure ulcer. All right, so I wanted to be sure that you saw that as well. All right, class, what I have up here on the screen is, again, an example of the Braden scale, and it's also in your book for your reading as well, so you have a copy of it in your concepts book. Just wanted to, again, bring it up for you. We did talk somewhat about this in Nursing 100 when we talked about tissue integrity. This is a great tool to use for predicting pressure sore risk for any patient that you may care for. Remember, it involves 5 categories: sensory perception, moisture, activity, mobility, nutrition, and friction. 6 risk factors, and friction and shear. The higher the number, the less risk your patient will have in developing decubiti. You can see when you do the assessment on your patient and add up all the points, this is how you interpret those scores, okay? Anybody that has anything under 9 is a severe risk, okay? And anybody that would be moderate or even mild, we'd want to evaluate, okay, what is the reason? Maybe their immobility is just temporary. And once people get up, or patients get up and move, their risk continues to go down and down. So that's a good thing. You can see that all these 6 categories are all extremely important in maintaining good skin integrity and preventing someone from getting a pressure ulcer. So I just wanted to kind of review the Braden scale with you. You had this in Nursing 100, but please review these categories and be familiar with how to grade the patient. 1 being completely limited, and 4 means there's no impairment at all. You can see the extreme from 1 to number 4, okay? And you'll notice in friction and shear, there's just 3 scorings, 1, 2, and 3. There isn't a 4th one, okay? So let me bring that down and show you. Number 1 would be there is a problem. Number 2 is there a potential problem. And number 3 is there's a no apparent problem, okay? And this is somebody who who's a potential problem. And I'm sure we have a lot of these patients where they're sliding a lot in bed, and you're having to occasionally, assist them, but they're not moving real well in bed. So this is what puts them at a potential problem for getting a decubiti. And that's why it's important every day part of the RN's assessment is to look at the skin and determine if there's any of these stages occurring, particularly stage 1 where we start seeing that blanching. So make sure you're looking at all those bony prominences, elbows, coccyx area, the hips. From your reading, they tend to occur over the heels, the greater trochanter, which is the near end of the thigh bone in the lateral aspect, the sacrum, the ischium, which forms the lower and back part of the hip bone. So those are areas you want to really pay a close attention to. And even a patient having on oxygen or a mask, the pressure from that particular device can even cause ulcerations in certain areas, especially behind the ears or under the nose. So make sure, things are not like Foley catheters and tubings that your patients may have are not putting extreme pressure on certain areas of the skin, causing them to, develop a cubiti or some ulceration in the skin. Be careful with tape when you're taping down IVs, that if you assess someone's skin and it feels very thin and tissuey, that you don't want to put a lot of tape on that area and then pull it off abruptly, because what you're going to do is take off the skin as well. And these are areas that will eventually develop some kind of further breakdown. So these are things we have to pay very, very close attention to. Okay. So again, just wanted to remind you about the Braden scale. Okay. And think of all the populations out there that are at risk for pressure ulcers, especially your military veterans with amputations that come back from their service overseas, or some of our veterans who have served in the wars might have amputations or even paralysis, and those will be people that definitely have a high risk of pressure ulcers, or someone that is constantly in a wheelchair. Hopefully those people have been educated enough to know how to prevent pressure ulcers in the way they have to move frequently or lift themselves up and make sure that, elbows and prony prominences are not having a lot of pressure on them. All right, what I have up here is just a evidence-based practice report on pressure ulcers. And it just talks about stating the problem: despite advances in healthcare to extend life and improve functional status, individuals with chronic illnesses and impaired mobility are at risk for developing pressure ulcers. The older adult with age-related compromised cellular activity is especially vulnerable to impaired healing of injured tissue, including pressure ulcers. An estimated 2.5 million clients in the United States are treated for pressure ulcers each year. And that's from 2010, and that was 10 years ago. So we know that those are probably much higher. Preventing pressure ulcers during hospitalizations and maintaining skin integrity after discharge require the cooperation and collaboration of the entire healthcare team. So this is just some studies that they did. A study conducted at a 166-bed acute rehabilitation center with a 2.8% rate of hospital-acquired pressure ulcers in 2007 focused on identifying the common causative factors. The most significant factor was misidentification of pressure ulcers at admission. So they really didn't do a very good job of assessing the patient when the patient came in, which unfortunately, since they didn't assess it and, realized that that patient was at risk for pressure ulcer, or for that ulcer to progress, that person that came in with a pressure ulcer, that ulcer did progress to a more severe staging. It was discovered that admitting clinicians did not perform thorough skin assessments, in part because they were not educated about what constitutes a thorough visual assessment. This omission in turn led to inaccurate application of pressure ulcer prevention and care protocols. Priorities identified for improving outcomes included staff education, wound care workshops, documentation, case studies, benchmarks, evaluation surveys, and staff newsletters and client education. Then they did a similar study that was conducted in 2009 at a 560-bed teaching hospital with a pressure ulcer acquisition rate above the national average. Protocols for care were discovered to be problematic for staff, particularly as they address support surfaces. Specifically, the staff were not fully educated in the protocols, and the protocols themselves were not appropriately streamlined. This situation created a jag between identification of pressure ulcers or at-risk tissues and treatment. The problem was compounded by difficulty in procuring proper support surfaces for clients with pressure ulcers. So priorities for improving client outcomes focused on developing staff education and awareness campaigns, streamlining existing protocols, and providing support surfaces to all clients. So again, another problem with education. So this third study was conducted at a large California medical center in 2019, yielded similar results. The center in turn launched an initiative to improve staff education and continuing training on ulcer identification and care. As part of this initiative, each unit was assigned a designated wound care specialist. Screening processes were also revamped and support services were replaced. So again, in all three of these cases, the facilities experienced a dramatic decrease in hospital-acquired pressure ulcer incidents after addressing the priorities identified. So they saw the common thread with all these three studies. Education is paramount for preventing pressure ulcers. Staff must be taught how to properly screen and examine clients at the time of admission and to stage ulcers after they are identified. Continuing education should be offered to keep skin integrity issues at the forefront of care and to keep staff abreast of protocol changes. Protocols should be clear and easy to implement. They should also address issues related to reassessment to ensure that ulcers are being regularly assessed for changes. Finally, support surfaces should be readily available and easily accessible. Staff should be trained on the proper use of these devices and how to identify the types of devices appropriate to specific client conditions. In addition, because pressure ulcers can occur both in and out of the hospital setting, education should extend beyond hospital staff. Clients and their family or at-home healthcare providers should also understand how to screen for ulcers and how to identify the changes in stage or condition. They should also be educated on care protocols and the use of support surfaces. So again, here's just something to think about. Consider the at-home care of a wheelchair-reliant older client with a spinal cord injury who has a stage 2 pressure ulcer at the time he is released from the hospital into the care of his wife who is in her 80s and mobile but frail. Identify potential issues that may result in the worsening of the ulcer and develop interventions appropriate to the age and condition of the client and his wife. Suggest 2 resources that the client and his wife could utilize to aid in his care and potentially improve the staging of his ulcer. And this is the kind of stuff that we see, where we do have an aging couple and one is, able to take care of herself, but not to the extent of caring for the spouse, who definitely needs constant care to hopefully provide care that will heal this ulcer instead of going the other way, which it could progress to either a stage 3 or stage 4. So I have uploaded this in your Canvas course, so you'll be able to have access to it and read it accordingly. But I just thought these were very interesting to see how each one of these studies kind of had that common bond of education. And of course, it was very sad for me to see that this first study showed that the patient was not really being thoroughly assessed, and they kind of missed the fact that the patient came in with an ulcer to begin with. So I thought that was quite interesting. All right, what we're going to do now is I'm going to go over some case studies with you, okay? So I will do that on a separate recording, and I'll be doing that just in the next few minutes. So thank you for your attention. I hope this has provided you a lot more awareness on how serious of a problem this is, and that we nurses have got to do a better job. Not that we're doing anything intentionally. I know we're extremely busy in the hospital, but this should be a priority, is really assessing and maintaining good skin integrity on our patients. All right, we'll begin going over these case studies in just a few minutes.